I'm the medical director of the thoracic oncology program here at Yale, and I am a pulmonologist, and I'm going to talk to you about pulmonary complications in cancer survivors. So pulmonary toxicity is very common among people who have been treated for cancer and survived. Up to 20% of patients who've had chemotherapy will have some pulmonary complications long-term, and up to 15% of patients with thoracic radiation also will have long-term complications. Many more patients will have immediate short-term toxicities, and I'm going to talk about that only very briefly. And we really don't know what the incidence of pulmonary toxicity is with the newer agents, including monoclonal antibodies, small molecule inhibitors, and all of the new cancer drugs that are coming down the pike. In the acute setting, the differential diagnosis of patients who have shortness of breath, cough, fever, or any pulmonary symptom, and who have radiographic abnormalities on chest X-ray or CT scan is very broad. And more than half of patients who present that way within the first weeks to months after their treatment, whether it's chemo or radiation, will actually have infection. And that's an incredibly important caveat to remember. It's infection until proven otherwise. But you can see that there are many things that can cause that constellation of symptoms and signs, including malignancy, both the primary and metastatic disease, pulmonary edema, acute lung injury, which we call ARDS, pulmonary hemorrhage, transfusion reactions, which when they're very severe in the lung we call TRALI, pulmonary emboli, particularly in patients with adenocarcinomas who tend to be hypercoagulable, and then acute drug toxicity and acute radiation injury. In the long term, what we come back to is that toxicity from chemotherapy as well as from radiation tend to come back later, weeks to months to years after treatment, and it's very important not to forget that in the care of these patients who have survived months to years after their treatment. The diagnostic tools we have at hand are history and examination, and history is incredibly important to give you a sense of the time frame. So an acute problem is much more likely to be an infection than a symptom like cough that has been insidiously progressing over months. Imaging studies include chest X-rays, which are readily available but unfortunately very insensitive, chest CT scans, which are readily available and sometimes too sensitive, and then PET scanning. What we tend to use for patients is mostly CT. The role of PET in evaluating patients after their cancers, long after their cancers, is unclear because things that cause inflammation, infection, or cancers will all make the PET abnormal. And there are some cancers that don't take up FDG, like renal cell carcinoma, and so the PET in those patients is often not very useful to look for malignancy. So that PET is probably not a good initial imaging study in somebody where you suspect there may be toxicity versus cancer because it's not going to distinguish those things for you. And then I'm a pulmonologist, and if you come to see me, you're likely to get pulmonary function testing, where we measure volumes and flow of air and something called the diffusion capacity, which gives us a handle on the pulmonary vascular bed and a very distant handle on the patient's ability to exchange gases like oxygen. The two parts of that test that tend to become abnormal with long-term toxicity are the diffusion capacity and then the size of the lung, because if there is scarring, the lung tends to shrink down, and we can measure that actually on a PFD. And then, of course, lots of patients do need biopsies to actually define what is going on. Toxicity tends to be a diagnosis of exclusion, and the things that you exclude really mostly are infection and recurrent malignancy. This is a patient that I had seen, 21-year-old woman who had a germ cell tumor who was treated with a bleomycin-containing regimen. And bleomycin is a drug that is actually used in the laboratory to incite pulmonary fibrosis in mice. And it is a very well-established and very well-used model for fibrotic lung disease. And it was based on the fact that we know it causes fibrosis in people. And so this is her baseline chest X-ray. Here is her double lumen catheter through which she was getting her regimen. She's not taking a particularly good breath, but her heart size is okay, and her lung volumes really look all right. But I got called to see her because I think it's obvious she developed diffuse pulmonary infiltrate. She was actually quite symptomatic. This unfortunately required then a change in her therapy, this acute toxicity, which we felt was related to bleomycin. Unfortunately, she was both cured from her germ cell tumor and all of this completely resolved. I still see her now many years later. She has normal pulmonary function and a normal life, which is pretty remarkable. These patients are very hard to evaluate. So if you're months and years after the cancer it's very hard to look back and say, well, if you are sitting in front of me now and are short of breath and have interstitial lung disease, is it because of your therapy months and years ago? And the reason for cancer patients this is very hard is that drugs are rarely used alone. The oncologists are incredibly fond of creating these acronyms, ICE, RICE, ABVD, CHOP. I don't even know what half of these things are, but they are the names of multiple drugs that are lumped together to really take advantage of the different characteristics of each drug. And in most cases, the combination of those drugs is better than any of them singly. And so to go back and say, well, are you sick now because of one drug in your regimen, or because drugs that were used in combination, or because your drugs radiosensitized you, so then the chest radiation you got caused more injury? Those are really impossible questions to ask. Insidious onset, weeks to months to years, should make us think about subtle inflammatory things as opposed to recurrence of malignancy. And unfortunately, there aren't any specific diagnostic tests, so physicians really need to be cognizant of the possibility of long-term toxicity and go looking for it. And most of the long-term toxicity related to chemotherapy involves pulmonary fibrosis. And whether you have acute lung injury, which you tend to get with cytotoxics, hypersensitivity, which you tend to get with antimetabolites, or syndromes associated with drugs like retinoic acid syndrome, IL-2 syndrome, if there is chronic impairment from any of those pathophysiologic causes, they tend to end up with the same result, which is that the lung scars. And so we immediately go and do pulmonary function studies on these patients, looking for abnormalities in diffusion capacity and lung volumes, and then do as sensitive a radiographic imaging study as we can get, which usually involves CT scan. If you do CT scans, about 50% of patients who receive radiation to the chest, either for breast or thymus cancer or anywhere in the mediastinum, have spillover into the lung, and you will see evidence of inflammation and scarring. But most of those patients do fine. The minority of them eventually have any injury that can be measured by PFT or visible on CT scan. There are predisposing factors like smoking, steroid withdrawal. Female gender tends to be a risk factor because women have a smaller thorax, and so there's deeper penetration of the radiation to the lung. These patients tend to have low-grade fever, cough, and chest pain. And the radiographic hallmark is that the infiltrate on the CT scan or the chest X-ray corresponds to the previous radiation treatment field. So these are geographic infiltrates that do not respect anatomic boundaries. They tend to look like ground glass opacities when you see them early, and then they get harder, patchier, homogeneous. They may be associated with a little bit of serositis, little pleural effusion, little pericardial effusion, though that tends to be a minor component. And it's always hard to tell, is there tumors still left in that irradiated area in the lung? And really, if it doesn't look like all this stuff, but it looks solid, you start to worry more. So then what about the long-term sequelae of radiation therapy? What about seeing radiation fibrosis in patients who have survived their cancer? It usually stabilizes, meaning it doesn't get worse and worse and worse, and whatever you have 1 to 2 years after your radiation is all hopefully you'll ever get. It is true that radiation fibrosis does not occur unless you had prior radiation pneumonitis, but you don't have to have had the short-term acute pneumonitis to get fibrosis later. So this is a 62-year-old man who's in our clinic now, combined chemotherapy and radiation for stage 3A non-small cell lung cancer. This is his baseline chest X-ray, and here is his cancer. So for stage 3A non-small cell lung cancer, the state-of-the-art treatment is combined chemoradiation. The chemotherapy is given partly to radiosensitize, and after the radiation is completed, they get systemic chemotherapy. And this is him, let's see how many months, 10 months after treatment. He's doing fine. As far as we can tell, his tumor is gone. He's in remission. But he had clinical radiation pneumonitis with cough and fever about 3 months after he finished his treatment. We treated him with steroids. He's feeling pretty well now. But you can see there's infiltrate here in the right middle lobe and infiltrate in the left lower lobe where his cancer used to be, but it's gone, which we're really happy about. But there is this very geographic look to that infiltrate, and the beam came like this. So that the beams for radiation are given at all different angles, but inevitably there's one field where it's given most intensively, and there was his field. And so he had classical radiation pneumonitis with the proof afterward to show it. He has PFT abnormality, but he's fine. And I think, from my opinion and his opinion, this was a small price to pay for curing his cancer. And so I'm going to close with just 4 points from 4 articles in the past number of years. This one by Lung, I like that one. It's a study from Norway, 116 long-term Hodgkin's disease survivors seen at 5 to 13 years after their treatment. And what was impressive was that 30% of them had dyspnea with measurable PFT abnormalities. So these are common in patients who receive radiation and chemotherapy. These patients weren't sick, but they were symptomatic from their treatment. So it saved their lives, but it left them with some impairment. And that's common in patients who have received chemotherapy. And when they did the multivariate analysis, this actually was related to this combination of bleomycin and anthracyclines, not so much to any of them alone. This paper by Lahani is more recent, and this is a really interesting follow-up, 25-year follow-up of 17 childhood brain tumor survivors. They've been treated with BCNU. They had started out as 35, but half of them actually didn't make it past the first year of the diagnosis. And this group, the senior author, which is O'Driscoll, actually followed these kids for many, many years. And what they saw was of the 17 survivors, so 17 long-term survivors, they followed them at 10 years and then again at 25 years. Half of them at the time of this study had died related to pulmonary fibrosis. So that patient I showed you earlier who had the horrible fibrosis after the bone marrow transplant, this is the corollary of that. And actually 7 of the 8 remaining survivors all had evidence of pulmonary fibrosis. So this is something, this kind of BCNU toxicity is something that they could not have known about at the time the therapy was given. It saved these children's lives, but it put them at risk, all of them, to have very severe pulmonary disease later, which was really unfortunate. And so pulmonary fibrosis comes back to haunt us with both chemotherapy and with radiation in survivors. Another study by Horwich and Swerdlow, these patients were given thoracic radiation for treatment of Hodgkin's lymphoma. And what we know now is that this kind of radiation given to young women really increases the risk of breast cancer. And so we're very careful about how much radiation we give to patients who've had breast cancer at young age who got chest radiation. The risk is related to the dose received as well as how old you were at treatment. And it's very clear that radiation to the breast is more carcinogenic at younger age, whereas radiation to the lung is actually more carcinogenic in older ages. And so it's very important to remember that. It means that we really need to look at these Hodgkin survivors for the risk for breast cancer. They need to be screened earlier, probably. And then this last paper by Villani documented what we see actually all too commonly, that long-term survivors of Hodgkin's lymphoma treated with radiation have increased incidence of cardiopulmonary disease. And what we're seeing now is that patients who were treated with cobalt radiation 25 and 30 years ago are coming back as cardiac and pulmonary patients. They survived their Hodgkin's, but several decades later are having complications of their treatment. So I think the lesson in all of this is that, as time goes by, you can't stop being vigilant. Patients who have had a history of cancer and who have fortunately survived are at higher risk for pulmonary disease the rest of their lives and need to be monitored carefully.